Okay, everyone, thanks for coming back in here after lunch. There's a couple of things I wanted to mention. The Wi-Fi is evidently the company's having outages, so if you're having trouble with your Wi-Fi, it's not our fault. Also, I wanted to make sure if anyone would like English to Spanish interpretation, that's available. I forgot to announce that this morning. And then there is a schedule change. The industry panel will actually be 45 minutes, and I'm really sorry because I know that kind of squeezes out the break. But again, the break snack items will be out there, so feel free to get up and move as you need to. And I think with that, I don't see many people flowing in, so I'm afraid they're still in the lunchroom. I think to keep things on time, we're going to go ahead and get started, and Dr. Helen Leonard is our first speaker.
Thanks so much, Karen. Yeah, what do I? It's just weird. Yeah.
And then we can, where's the thing? Oh, there it is. Okay.
Coming up? Yeah, okay, lovely. Well, thank you very much for inviting me here to this very important family conference. I'm very honored to be here. So, some of you may have heard this story before, but I would like to begin by telling you how I originally got involved with the CDKL5 disorder. In 1993, I started a population database of Rett syndrome in Australia. A few years after that, I come from Western Australia. A colleague of mine was involved in a familial study of autism in Australia, and she was visiting families throughout Australia who had more than one apparently had more than one child with autism. She visited the family here where there are two twin girls and also a brother who'd previously died. And she gave me a call and she said, I've just seen a girl with Rett syndrome in this autism family. Anyway, it turned out that this girl had what we called then the early onset variant of Rett syndrome. She had the features of Rett syndrome, but her seizures started very early. So naturally, at that time, we didn't even know the genetic cause of Rett syndrome. In 1999, mutations in the MECP2 gene were identified as the cause of Rett syndrome, but no mutations were found in this family with the twin girls, one who appeared to have the early onset seizure variant, one who had autism, and they had a brother who died of a severe neurological disorder. So in 2004, after much researching, a mutation in the CDKL5 gene was identified in this family. So this was the beginning of my journey into CDKL5. About the same year, I visited Europe, and this paper that you can see here was also published at the same time. And I visited this set of twins in the Netherlands. Now, since that time, one of the twins has died, but the other one I worked out must be 55 years old and apparently is still alive. So we as well as a population database of Rett syndrome, we had an international database known as Interrett. And in that database, we had children and adults with the early onset seizure variant, so-called, who turned out to have a mutation in the CDKL5 gene. So what we decided to do was compare the characteristics of those with a CDKL5 mutation with those with classical Rett syndrome with a MECP2 mutation. And the result of that study was that we really declared CDKL5 to be an independent disorder. And as you know, it's extremely likely that seizures will occur within the first year of life, generally the first 3 months, global developmental delay, and severely impaired gross motor function. Other characteristics are sleep disturbances, abnormal muscle tone, teeth grinding, and gastrointestinal issues. But less common is independent walking, microcephaly, small head, and major birth defects. But you can see that you probably can't see it properly, but the picture on the left shows that some of the children had facial characteristics which resembled each other. But we knew something then about the CDKL5 disorder, and we knew it was an independent disorder. But there was so much more needed to know about many aspects of this disorder, including how the diagnosis was being made, the natural history, the life expectancy, the clinical variation, the appropriateness of interventions currently being used, and the possibility of cell-based treatments. And so, in 2012, we established an international database for CDKL5, not just for Rett syndrome. And this was a collaboration between ourselves at the Telethon Kids Institute in Western Australia and IFCR. And we started recruitment in 2012. So we aim to collect information from families around the world on the developmental history, the functional abilities, seizures, including treatments, other medical problems and their management, and the impact of having a CDD in the family. So families could register through the website of IFCR, and once they registered, we would contact them, explain to them about the database, and then we would provide them with a login and password, and they would log in here and complete a questionnaire about their child. So now we've had over 400 registrants from countries across the world, and you can see the horizontal axis represents the years. So we did start before 2012 ascertaining through Interret, and since then it's been through the international database. And you can see here, I hope you can see here on the left, the age distribution of those in the database at the time of ascertainment. And almost under a half are now under the age of 2 years when their families join the register. Although we've also got a proportion of older men and women over 20. On the right-hand side, you can see again the distribution of countries from where the children and adults come. Almost half from the US, but the UK, France, Australia, Canada, Germany are all well represented. And over 40 families from over 40 countries have contributed. Now, I just want to mention the structure of the CDKL5 gene, because when we're looking at epilepsy, we have looked at it according to genetic groupings. Now, you can see, you probably may or may not be able to see that now we have details available on 290 individuals with a definite pathogenic mutation. But of these 290 individuals, there are 217 distinct pathogenic mutations. So these are, and of those, only 35 are recurrent. So only 35 of them occur more than once. And so the maximum number of individuals for one single mutation is 8. And only 6 mutations have more than 4 individuals. Now, I stress this because what we would like to be able to do is to find out whether there are particular characteristics associated with specific mutations. But to do that, we need to get larger numbers so that we can do that in analysis. In the meantime, we have just grouped according to the groupings you can see here. Group 1, they've got no functional protein. Group 2 are the missense in-frame mutations within the kinase domain. Group 3 are the truncations between AA171 and AA781, and group 4 are the later truncations. So I will refer to these groupings as I go through my talk. So just to let you know, this is the family questionnaire, which families have filled out and which have provided the data for this presentation. It can be completed either online, on paper, or by telephone interview. It's already translated into French, German, Portuguese, Russian, Italian, Japanese, and Mandarin. And I brought a paper copy of the Japanese version for the Japanese family, if they're here. So these are just some of the ways in which we've contributed data to understanding CDKL5 in relation to the developmental milestones, the functional abilities, the parent well-being, other medical problems, and also the types of mutation that occur. What you can see here is our website where you can go and you can search on that database for characteristics associated with CDKL5 by age group, by mutation group. And that's just one example. That is sleep problems by mutation group. And this one here is mobility, independent walking by mutation group. So now, just focusing on seizures, which is the topic of the talk. This analysis was carried out on 240 cases with a confirmed pathogenic mutation about 7 months ago. The majority of the cases were female, 86%, and nearly 50% were between 1.5 and 6 years of age. We used what you call time to event analysis to look at the age of seizure onset, and we looked at regression methods to see whether there was any relationship between the current seizure rates and functional mutation group and functional ability. This is just the distribution of the cases, the epilepsy group and the no epilepsy group, by gender, by country of residence, and by age ascertainment. And this is just the distribution by the genetic groupings that we used. Now, what we showed was that, as we probably knew, but we knew we had to verify this, was that the median age at onset of seizures was 6 weeks. It ranged from 1 week to 18 months, and we didn't find any variation by mutation group. We also looked at the current frequency of seizures and found that about 2/3 had had 1 to 5 seizures per day or more. And there were only 8% who were seizure-free for more than 2 months, which is what we want, of course, to attain. This is the seizure frequency by age group, and we didn't really see any dramatic differences across age group in the frequency. But this is cross-sectional data, and we will soon have longitudinal data, which will be much more meaningful in this regard. Originally, we had 3 individuals who never developed seizures. One of them was the girl I showed you in the very first picture who had autism but had a CDKL5 mutation, but she never had seizures. Another was a boy who didn't have seizures when he was ascertained, but I believe he actually has developed them since, and another female. Now, this here, you'll probably be aware of the fact that children with CDKL5 disorder often have a honeymoon period, so they have a period of seizure freedom. So we mapped this out according to the families who told us that they'd had a seizure-free period. And in the dark blue relates to their actual seizure-free period or honeymoon period, and the orange relates to the ones who actually continued to be seizure-free. So the honeymoon period occurred at a median onset of 2 years. It ranged from 2 months to 11 years, and it usually lasted about 6 months, but it could go from 2.5 months to 6 years. Now this slide just shows the characteristics of those who were seizure-free, and really it's quite a quick mixed group, more females than males, but females are commoner. The mutation groupings are fairly mixed, and the medications that these children and adults were on before are all sort of different combinations. Currently, more than half of them were not on any medication at all, but 4 of them were on medication, and 3 of them were on combination. 3 of those 4 were on combinations of medications. 3 of the children/adults were able to walk independently, and quite a number were able to use single words. On the medications. See what? Phenobarbital. Oh, PB, yeah, phenobarbital, right, yes, thank you. So this shows you the relationship between the current seizure rate and both the genotype, the genetic grouping, and functional ability. So where you see here we've got a reduced rate ratio for these missense mutations. So this means that their rate of seizures is less than those with the no functional protein. Similarly, for those truncations between AA172 and AA781, their rate of seizures was lower. Also, those who were able to walk independently had lower rates of seizures. These are, this is the first analysis we've done. As our database grows, we may repeat this, and the results may be different. But this is what we saw at this point in time. Now, this here just shows you the same information in a graphical way. So this is looking at the relationship between missense in-frame mutations and truncations between AA172 and AA781 and no functional protein. And you can see that the rates are reduced for these 2 groupings, slightly reduced for the other truncations, but not significantly so. So this shows us the commonest anti-epileptic medications and combinations currently being used at that time. Now, there are a lot of different medications being used and a lot of different combinations. But levetiracetam, Keppra, was the commonest one, used by 1/3, followed by valproate, just under 1/3, and clobazam. And then the combinations, Keppra and topiramate was the commonest combination, followed by clobazam and valproate by itself. Now, these are small numbers for these combinations, but if you think of all the AEDs and think of all the different ways they can be combined, you'll find that there are a lot, I would guess, at least 100 different potential combinations of drugs. So what I've said so far is that almost 2/3 had 1 to 5 seizures a day or more, and only 8% were seizure-free, and we haven't been able to detect any improvement with age so far. Both genotype and functional abilities were related to seizure frequency. Most of the individuals were on polypharmacy, with almost half on 3 or more medications. and Keppra, valproate, and clobazam were the most commonly used. So there are other forms of treatment in addition to typical AEDs, and one is the ketogenic diet. And we found that just about half of all the case individuals in the study had at some point or other used the ketogenic diet, with an average duration of about 17 months. Now, families reported that there were changes in seizure activity after commencing the ketogenic diet. Two-thirds reported that there were changes, and of that two-thirds, 89% reported improvements. But nearly one-third also experienced side effects. And at the time of data collection, only one-third of those who'd been on the ketogenic diet remained on it, with lack of long-term effectiveness as the main reason why the families had stopped the diet. But there were, as well as the relation to seizures, there were other positive and negative effects associated with the diet. The positive changes included improvement in alertness, increased eye contact, and more smiling. The negative changes included decline in motor and social interaction and potential episodes of regression. So the reasons for discontinuing the diet were lack of long-term effectiveness, severe side effects, such as gastrointestinal side effects, inadequate weight gain, and liver or kidney dysfunction, worsening seizure activity, and or difficulty in administering the diet. So to summarize the use of the ketogenic diet from our data, there can be initial improvement which occurs quickly, but there is poor long-term efficacy. Children were usually on the diet for a median time of 17 months, but those who were being peg-fed tended to be on it for longer. There may be additional benefit in starting the diet early. And the improved alertness that families reported was consistent with some results from animal studies. Now, I'd like to mention briefly the use of vagal nerve stimulation. VNS was first proposed in the late 18th century as a treatment for seizures. It involves intermittent electric stimulation of the vagus nerve through a pulse generator device. It was approved by the FDA in 1997 as an adjunct treatment for partial seizures in adults and children over 12 years. But recent US FDA approval the FDA have approved it for use in children as young as 4 years. So this again is the characteristics of the study population by gender and country of residence. You can see that, these are very small numbers, I'm sure not statistically significant, but there was higher use in the UK, USA, and Australia than in other countries. The age of ascertainment, this is obvious that because once the VNS is inserted, it usually is maintained, therefore we had a higher proportion in the older, those who are over 12 years. And a slightly higher proportion in those who had mutation group was not grouped. So we found that this time much less commonly used than the ketogenic diet. It was reported for 16%, 36 out of 223 individuals, and they'd been on it for a median duration of 3 years, 9 months. Improvements in seizure activity after insertion of the VNS were reported for nearly 2/3. And in 6 individuals, an increase in alertness was also seen following this insertion. And in 3, an improvement in mood was noticed too. Of the 36 who had used the VNS, 3 were reported to experience a deterioration in behavior, eating, or sleep quality, and in 2 of these, the VNS had actually been turned off. In 2 other individuals, the VNS had also been turned off, one because of lack of effectiveness, and the other because of breathing difficulties, which is a known side effect of the VNS, but only really affects about 1 to 2%. So finally, I want you just to report to you our descriptive observations of the use of medical cannabis in CDD. Now, our data source, again, was the CDKL5 International Database, but we used both the initial and the follow-up questionnaires. And the data were extracted as at 7th of June this year. Now, we've only just commenced our follow-up study. We commenced it at the end of April, so we're still inviting families, and any families here who have not yet been invited but have filled out the baseline questionnaire are most welcome to let us know, and we'd love them to participate. So as at the 7th of June, 122 families had been invited, and 75% had already responded and provided data. And these numbers have actually increased since that time. So, but this presentation is based on data from the 69 families who had provided information on the use of medical cannabis. Among them, 39% had indicated that their child had ever used medical cannabis. 18 were current users and 9 were past users. So this is, again, the characteristics of the individuals using, and this is not representative because we have invited more people from the US and Canada and Australia initially, but anyway, most were from the US at this point. Now, you may not be able to see the details on this chart, but what it shows is that in the first table is the current users of medical cannabis, and so as you can see, medical cannabis, they've got a tick along the first row, and that's what they are on at the moment. And the green ticks are what other medications they're on. The red crosses are what they were on previously. What we would like, so you can see, for instance, the first individuals on medical cannabis, also on topiramate, and also on diazepam and midazolam, probably as rescue medications. The second individuals on medical cannabis and also on clorazepate. What ideally we'd love to see is that, you know, when they start the medical cannabis, they come off the other anti-epileptic medications. The other table is for those who were previously on medical cannabis but no longer using it, and again, the green ticks represent the medications that they are currently on. So we have got, I will first of all describe to you the results from the current users and then the past users, and they are different. So of the current users, the median age that was started was 18 months. And the product type, quite a variety of different strains, which I must confess I'm not very familiar with, on cannabidiol only and on Epidiolex. And the cannabis was prescribed by a health professional in 7 families, and 6 of these were from the US, 1 from Canada. Now, this is what families reported. These are the current users, and they report 16 families reported an improvement in seizure control. 2 did not respond. And these are a couple of the quotes. Went from 3 tonic-clonic seizures a week to 1 every few months. Before CBD, child went no more than 4 days seizure-free. When CBD was added, she went weeks, sometimes months, seizure-free. And these families also reported other benefits: alertness, cognition, developmental progression, improvement in appetite, sleep, mood, and motor function. Now, we tried to analyze, we only had 7 individuals who in the first questionnaire had not been on medical cannabis and were now on medical cannabis. And we tried to analyze the current seizure rate in the 2 groups. And we adjusted it for age and for the number of anti-epileptic drugs used. And actually, we found the opposite from what the families had told us. We found that the rate of seizures was higher than using cannabis than it was without. But take all this with a pinch of salt. These are very preliminary data. And what might have happened for these families is their children's seizures might have got worse in the interim, and then they might have improved, with the cannabis. But I'm only just showing you this as an example because really very small numbers, and we do hope that we will complete our follow-up study in the next month or so, and we'll have much, much bigger numbers. But the other side of the coin, I've reported to you on the current users. We get a different picture when we look at the past users. So these are the people who used the medical cannabis previously. And again, strain, Charlotte's Web, THC /CBD unknown, an unknown brand, cannabidiol only, Epidiolex. And in this case, it was prescribed by a health professional in 5 families, the USA and Australia. Now, these families told us a different story from the ones who are currently using medical cannabis. They told us there was a transient improvement in 1, in 2, there was no effect, in 2, the seizures worsened, and one case was used only for weaning off the AEDs, another stopped because of VNS insertion. So this is the story of those who used it in the past. The other was the story of those who are currently, and as you can imagine, if it's not working, stop using it. So just in conclusion, epilepsy is pervasive, but not mandatory in the CDKL5 disorder. Genotype and functional abilities related to seizure frequency slightly. Seizures are refractive, but there can be positive responses, both to the use of ketogenic diet and the vagal nerve stimulator. And further research on steroids in infancy and the role of cannabinoids and other medications such as ganaxolone is needed, ideally in prospective trials. So, should I now pass you on to Scott, who will continue the study?
All right. So my name's Scott Demarest. I'm one of the epileptologists here at Children's Hospital Colorado, and I appreciate the opportunity to talk to you guys about epilepsy a little bit. It's going to be interesting hearing my talk after Helen's wonderful talk because we have similar things that we're trying to look at, but from 2 different ways of collecting data. But I'm going to start by just kind of orienting everybody a little bit to some of the terms for those who are maybe newer to dealing with epilepsy or haven't had somebody who's taken the time to talk about some of these things. We'll go through what are we talking about when we say different types of seizures and some of that kind of basic stuff. I have some support from IFCR and from the NIH, and I appreciate that very much. So what do I want to try to get across to you today? A basic understanding of what epilepsy looks like in CDKL5 in general. There's a lot of variability. We'll talk about that as well. Again, explore that idea. Does the particular mutation influence what the seizures look like? We call that genotype-phenotype correlation. Are there elements of the phenotype? Phenotype's a fancy word for what do things look like, or what are the cluster of symptoms that are associated with a particular outcome that we're looking at, and I'm going to talk a little bit about development as the outcome of interest in that case. So, sorry, I don't know what happened there. Just so that everybody has some basic concepts about epilepsy in the room for families who, again, haven't been exposed to this. Most of the time as epileptologists, we think about epilepsy in two big categories: generalized seizures and focal seizures. Focal seizures can look like almost anything. Wherever that seizure is occurring in the brain is going to determine the symptoms or the way that it appears on the body. So if it's something that's in your motor area, you're going to have a motor seizure. If it's something that is in emotional centers, you might see emotional aspects to the seizure. And so it can look in pretty much any different way, depending on where it is. Generalized seizures are seizures that either hit the whole brain at the same time or very rapidly spread to the whole brain at the same time. But they also come in a variety of flavors. The most common one, and the one that we hear talked about all the time, is generalized tonic-clonic seizures. Those are the typical seizures that you think about when you hear seizure before you had to live in a world with seizures and learn more about it. And that can actually start focal and become generalized if it spreads. Generalized tonic just means whole body stiffening. Myoclonic is a term for a quick jerk. Absence is staring spells, but you can also stare with focal seizures because we want to be tricky. So those can be hard to distinguish sometimes. Atonic means no tone, so it's a loss of tone or a falling down seizure where it's like the puppet who gets the strings cut. So I'm going to use some of these terms throughout the talk, so I wanted you guys to see that. Epileptic spasms fall into their own special category because we can't decide as epileptologists whether they are focal or generalized, and they can be both, and they're different in different patients, and so they kind of fall into an other category. Again, just to orient of what are we talking about when we say focal or generalized. This is an EEG. It's not a CDKL5 patient. We have a map where each of these different electrodes that are producing a line of squiggly signals that are representing brain waves in any particular part of the brain. So we put it together as left and right, a strip down the center of the head and a strip over the ear, and we're comparing one electrode to another. So if you think about the concept of generalized versus focal, the spikes are what we're looking at as being epileptiform or having to do with seizures, being an indication of a risk for seizures, or in some cases an actual seizure, depending on the context. On the left side, you see spikes all over the electrodes, right? In every electrode in the brain or all over the brain, you're seeing that same activity. On the right side, you're only seeing spikes in some of the electrodes. So that's a focal, and the one on the left is a generalized. So what about CDD specifically? You guys have heard this. This is not new information to anybody in the room. We talk about a severe early onset epilepsy that's often very hard to treat. We talk about infantile spasms often without hypsarrhythmia, and I'll talk a little bit about that in a minute and why we care. We talk about some special seizure types, hypermotor tonic spasm sequence, and I'll get into that detail a little more. Rett syndrome, which Helen nicely alluded to, often is associated with a course where there is a regression in development at some point, and that's actually much less common in CDKL5. We know that the development can be very severe for patients with CDD, and I'll give you some numbers on that. And then something that we haven't talked as much about, but I think is really important, and Tim and I are trying to get into a little more, is the role of cortical visual impairment. Cortical and visual impairment is important to understand. This is not the same thing as blindness. This is your brain's ability to interpret the signals that are being sent from your eyes. And I'll talk a little bit more about that in a minute. So when do seizures start? This is a similar kind of graph to what Helen showed. This is 92 patients that are seen at one of the centers of excellence, and when did their seizures start in weeks? And what you can see very easily is the vast majority are within the first 10 weeks. We have a median age of 5 weeks, which is pretty similar to Helen's numbers, where she had 6 weeks, and that could range from at birth, essentially, to one patient that was not included on this graph because I couldn't scale it if I did. They had onset at 468 weeks. Again, variability. So, of those seizure types that we talked about, what is the first type of seizures that tend to happen? What does the initial presentation look like in terms of seizures? So, the most common is tonic. This is whole body stiffening. Epileptic spasms are frequent. Generalized tonic-clonic seizures, similarly, can be pretty common. This idea of hypermotor tonic spasm sequence. This is, hypermotor means you're moving a bunch of limbs, but not in any sort of rhythmic way. That can transition into the stiffening episode and then can be followed by a series or a cluster of spasms. When I say HTSS in this case, I'm actually not being that specific. That's the classic description that has been provided in the literature. But we've found in talking with you all that it's often not that stereotyped, but it often is a combination of tonic seizures and spasms. They may happen in any order. There may be a hypermotor component. There may not be a hypermotor component. But this idea of those particularly tonic and spasms clustering together, plus minus maybe another type thrown in. And sometimes that even happens as the first seizure type very early. Clonic is just rhythmic jerking. And then myoclonic is the jerking, but just a single one or more sporadic, spread out, not rhythmic. So if we then look at this at any time, not just what their first seizure is, but what types of seizures do they have, you still see that the vast majority of patients have epileptic spasms. What's the difference between infantile spasms and epileptic spasms? Infantile spasms are epileptic spasms that happen in infancy. So there's the same seizure type. It's just one happens in infancy. Tonic seizures, again, hypermotor tonic spasm sequence is common. It's not universal. Myoclonic, generalized tonic-clonic, focal, clonic. Atonic, this drop the string type, and the staring spells are actually pretty uncommon overall in CDKL5. So we keep talking about hypsarrhythmia. Most of the families in the room are probably like, so what? For neurologists, this is a big deal. If you look at all patients who have infantile spasms, 80% of them have hypsarrhythmia. Hypsarrhythmia is a particular pattern on the EEG. And for years and years, we've actually thought that that pattern is the encephalopathy. It's the brain not working right. It's the thing that damages development as you go forward. More recent data is starting to kind of question that a little bit outside of CDKL5. Is it just that? Is it the infantile spasms by itself? And so I think we're still trying to grapple with that, but that's the historical thought process. And it's actually, so it's a little bit of a clue if you have a patient who has epileptic spasms but no hypsarrhythmia, that you might need to think about CDKL5. And so that's an important thing for us to educate the medical community that this might be a clue of the diagnosis early on. The other thing that I think is really important about it is that the EEG background for hypsarrhythmia is a spotlight in your face as a clinician. It's really obvious. It's not something that you miss very often. But epileptic spasms on an EEG can be very subtle. They can actually be challenging. So this could be an element where you can get a delay in diagnosis, where it can be challenging, where you guys are going to hate us and be very frustrated with us. And this is part of what explains some of that. Helen presented some nice data about the honeymoon period or the breaks in seizures. And this is a format that we are presenting some of that data. I think the top line tells us that nearly half of all patients have a break in seizures at some point in time. Then we get a breakdown on sort of how long is that break in seizures. And it's a little bit all over the board. But even up to 3 months is pretty common. 12 months is a little bit less common. Of the patients that we saw out of our 93 patients, there were 12 patients who had at least 12 months of seizure freedom, and only half of them were still seizure-free at our last visit. Okay, so part of the challenge is that although we get a break, it often doesn't last. So coming back to that idea of cortical visual impairment, it's a rough schema of what we're talking about here. Eyeballs are the little globes at the top. It's seeing the world. that signal has a pathway that has to get back to the very back of the brain. That's where we interpret what we're seeing. And just like many things in CDKL5 that aren't quite working right, the ability to interpret the signals that are coming in is not perfect in many patients. That's cortical visual impairment. The important thing to realize about that that's different than blindness, where you can't get a signal, for example, this is not all or none. This can be a wide variety of symptoms. It may be very subtle, it may be very mild, or it can be quite severe where the brain's not interpreting much at all that's coming through. And we're trying to figure out how we can actually measure that and see the importance of it and use that to help treat better. And so that's an important concept, I think, for all families to have. When we looked at the Centers of Excellence data, 75% of our patients had some amount of CVI. We couldn't say that they had totally normal vision, okay? So 25% had totally normal vision to the best of our ability to assess that. But that doesn't get into how severe it was. So we are curious, how does that relate to some other things? And I'll show you some data on that in a second. Again, Helen already introduced this idea. They were nice enough to create this map of the gene for us that we've shamelessly acquired and used for all of our research going forward. And so we used the same grouping that they did so we could compare across our different data mechanisms. This is some of their data. Again, they looked at some basic developmental outcomes: sit, stand, walk, raking grasp, pincer grasp, babble, single word. And they were able to see that there appeared to be some differences depending on the gene mutation type for whether or not you attain certain things. So we wanted to know, what about epilepsy? Do we see differences in the way the epilepsy looks, how severe it is, whether we treat it with certain things, the types of seizures, the onset, based on whether you have a particular mutation? And we have come up dry. We don't have a perfect data collection system, and I think that's important to recognize here. But from the data that we're able to pull easily from chatting with families, we were not able to see that the types of seizures that you're having, whether you have those breaks and how long those honeymoon periods are, they don't seem to correlate with the type of seizure or type of mutation that you have. I think that there's things that we could improve upon in terms of how we're collecting that data. Helen's data is actually better at looking at severity and frequency of seizures and some of that sort of stuff than what we have. So what about cortical visual impairment and genotype? Is that different from one gene to another, or one mutation type to another? No. We couldn't find any correlation at all. The same percentage of patients with any type of gene was essentially affected by overall, do they have cortical visual impairment or not? Again, we're still working on trying to come up with some sort of scale where we can measure the severity of CVI, and that will then require us to look at this again. So coming back to this idea that Helen has set up using these 7 basic milestones, are we able to do that? Part of why this is nice is they're easy to measure, and we can say you have this or you don't. And that's sort of straightforward. So we looked at that with our population, and we created a score of these 7 things. If you have attained a particular milestone, you get a point. If you haven't, you don't get a point. And that's just a way to turn this into a numerical value, and so we have a 7-point scale. 0 means you have not attained any of these skills. 7 means you've attained all of these skills. And this is what it looks like. So we looked at the different seizure type or different mutation types. We looked at overall, and there wasn't really any difference as entire groups in terms of whether or not they've attained a certain number of these milestones. So the genotype-phenotype correlation is not playing out as well for us as it did for Helen. So what if we use that as an outcome? What if we say, I want to be able to predict for a particular child, are they likely to attain X number of milestones or not? I understand not every family wants to know that necessarily or not, but we like to be able to have some of that data and offer that if people want it. So we tried to look at the seizure types, the seizure frequencies, the hypsarrhythmia, any of these things. Hypsarrhythmia has been known to be predictive of a lot of different outcomes in other disorders. So does that correlate with the number of milestones that a patient achieves? CVI was the only one that came up with anything in our data set so far. And what we found is demonstrated here. So one thing's clear, as you get older, you attain more milestones. That's not surprising. So we excluded all of our patients who are less than 1 year of age because that's not fair to say that they should have attained these milestones yet. And then we said, okay, if you look at their age in comparison to their milestones and you look at whether they have normal vision, no CVI, or they have some amount of CVI, is there a difference between those two groups? And the red ones are the group that appear to not have CVI. And we saw that on average, they had 2 more milestones that they were able to achieve compared to the group that had CVI of some kind. And I think, 2 milestones is a big deal. I actually think that that's not trivial. That's a big difference in terms of function, quality of life, and whatnot. This doesn't tell us anything about chicken or egg, right? This doesn't tell you CVI is causing the developmental problem or the development is causing CVI. It's just, is CVI some marker for us of overall function? Does it give us some sense of how well the brain is working? And it may have some value there that we need to look into a little more. Helen talked a little bit about treatment of epilepsy, and I'm going to just touch on it very briefly because the whole next hour is actually dedicated to what's new and what's interesting and coming down the pipeline for treatment. The honest truth is that epilepsy is really hard to treat in CDKL5. I treat a lot of different types of epilepsy. They're all hard to treat, and CDKL5 can be one of the hardest. What do you take away from that? There's no single med that's going to be right for every family or every patient. I know every time that I talk about a med with one of my families, they say, but so-and-so tried it and it made them worse. And I say, yes, but I also know 3 other people that it helped. And the opposite's going to be true too. And there's no single one. You just have to keep trying. In doing that, you have to be methodical. You can't make 5 changes at the same time and expect to have any clue what helped, what hurt, or anything else. You have to try to do one thing at a time. You have to give it some time to have an effect. The changes that you see will not necessarily be right away. And we all know that epilepsy fluctuates dramatically hour to hour, day to day, week to week in patients with CDKL5 deficiency disorder. And so if we don't give enough time, I don't know whether or not the change that we made happened to coincide with something else that was going to happen anyway, or whether the medicine actually did something. So it's frustrating and it's hard, but my experience, we tend to head the right direction in the long run if we can be methodical, a little bit patient when we can, and have very specific goals. What about the epilepsy is the biggest problem, and can we target that? It's not necessarily that we're going to make every single seizure type stop, but can we say status epilepticus, really long seizures? That's what we're targeting. Clusters of seizures are our biggest problem. This particular type of tonic seizure is our biggest problem, but we don't really mind the myoclonic so much. And that's different for every family about what is having the biggest impact on the quality of life of their child. But you have to have a meeting of minds with your provider to where you are both targeting and have the same goals for your treatment. More to come next hour about what's coming down the pipeline and some exciting new opportunities. A quick summary here. CDD, typically we know, is associated with a severe epilepsy, starts very early, but there's a great deal of variation in that. Epilepsy, as far as I could tell, is not so far associated very well with the genes that you have, gene change you have. CVI is very interesting because maybe it tells us a little bit something about the overall function. And again, just to drive this home, Dr. Banke is phenomenal at this, and he can look at a child pretty early and actually tell, do they have CVI or do they not? What's their vision like? Before they may have attained some of these milestones. So can it be a clue for us that gives us some value about where is this headed, where are we going? Special thanks. These are my 4 boys. They're my rock and center that, helps me with all of this, and I thank you. How are we?
Everyone, we are loading our 2 o'clock up. Don't move. We're going to do some fun things with this 2 o'clock. We have a lot of great speakers on the panel that Scott's going to be moderating. And we are also going to make our best technology attempt to let you submit questions during the panel itself for the panelist. So give us just a minute to load the AV, and we'll be right back with you. So don't move or grab a bathroom, but don't go too far.
And there will also be a lot of question and answer time in the next hour.
Exactly. And then we're back to back with the 3 o'clock, which is our industry panel. So a lot about treatments and therapies this afternoon. Don't go anywhere.